In 2019 there, I started having just loose motions. I'll have like debilitating pain, and I'll have like 4 to 5 motions, and I can't like go to school. I can't go to class. I'm not skiving because we are skiving class, but it's because I'm actually having episodes. But I didn't know they were called episodes then. And then also this year, that year I had started, I think, my contraceptives. And I think it was also another trigger for me. And then our diet, despite me having a gallbladder removed because of the diet, I don't think I ever changed my diet that much.
You like
so
suffering.
I'm still, yeah. Because now, you know what happens when you have cholecystitis? You are so fat intolerant. You can't even have a bite of anything fatty. You can't you can't do anything. So then the moment the problem was removed for me, I was like, I can have pizzas again. I can have chips again. I can have all this. So I used to indulge. And then we're in med school. You can have the pizza pie and move on and go back to class and like continue with your ward round. So it's easier to have the fast foods. And I remember thinking, I have IBS. Like IBS was the thing. So you're like, oh, let's just do a colonoscopy first before we confirm. Because what I didn't know then was IBD has to be confirmed on colonoscopy first before you ever think of IBS things. So we did all of our tests. We did a colonoscopy, and that's when we confirmed my diagnosis that I have IBD. And I remember texting people, oh guys, I have IBD. And then that's it. Like I started taking mesalamine and my life changed. Like I don't have runny stool. Like I don't have to think about, oh, let me eat something so that I don't go to ward round and I'm feeling like I'm gonna have a runny loose stomach and I have to pop an Imodium so that I stay in that ward round. Because I feel like I couldn't survive in even ward rounds. Getting the diagnosis actually helped my life because now I could think of, oh, there's medicine I can manage, I can do this, I can avoid.
Hi guys, welcome back to A Dose of Health, the podcast where I give you not too little, not too much, but just enough information to help you make an informed decision. My name is Dr. Hope Simiyu, and I am the host. And today I have two lovely guests, and we'll be continuing a conversation that we started, but now we just added one more person into that conversation. So I'll allow them to introduce themselves before we go on.
Right. Thank you very much, Dr. Hope, for having us. My name is Edna. I'm a gastroenterologist and a consultant physician.
I'm Samira. I am also a medical doctor, but I lead a telehealth unit at my dawa.
Okay. Karibuni sana. Now, because I think I asked Dr. Edna previously how she was feeling, how she was doing. Now, Samira, you've done this before, but it's been a while. Where are you at today? Mentally, emotionally, how are you feeling? And first of all, happy Eid.
Hey,
yes, happy, because you're filming during Eid. So happy Eid.
Personal life, I think still I feel content and just calm. I feel like, there's someone who said previously on your podcast that last year was the year where things would happen to you, but your body has, has decided we can handle anything that comes.
No weapon mode. You're just there.
I don't know if you call it something. I forget. But so that's where I am. So no matter what happens, I'm just like stable, like content, and happy. And then in my, I think, work life or like career-wise, I'm now like very curious because we are in the Claude, ChatGPT era where my life is being made so simple, so much simpler with Claude, and like I can come up with analysis on the spot for all of the patients I've seen and things like it's so entertaining just to not to be able to. I love our data analyst. Let me start by that, but not to be able to be like, can you please analyze this data for me? And then I wait for a whole day. Now I'm just like 5 seconds. Claude, analyze all this data for me for the entire year, and it does it in 5 seconds, and I love it.
Shout out to AI, by the way. Shout out to you.
I stay curious now.
Good. Yeah. Okay. So welcome back. And before we continue, so now I did the doctor seat with Dr. Edna, and I know you're a doctor, but today you're going to be in the patient seat.
Yeah. I consent.
So I have a segment called now the patient seat. So just a few questions that you answer. Don't overthink it.
Oh, interesting.
Yeah. Okay. So the first question, on a scale of 1 to 10, where would you place your trust in the Kenyan healthcare system and why? Maybe Doc, you can answer as well.
I know.
See, I have hacks.
Okay.
If I wasn't a doctor myself, I think the trust would have been much lower. But because I've already formed a network of people I trust for every diagnosis I come across personally in my life or with my relatives, then I'm still at a 6.
Okay.
So I think because I've created this network, I'm at the 6.
Okay.
But if I didn't have this, I think I would be at a 2,
Oh. Okay.
to be honest.
All right. What about you?
I think about it in 2 ways: the private sector and the public sector.
Okay.
I'd place the public sector at about a 2. It's really underwhelming, underperforming. A lot needs to be done. But for the private sector, I'd put it at 7. I think we have very, very good specialists out there, maybe not talking about themselves. We have good hospitals. We have very good equipment. Long ago are the days when patients would have to leave the country to do tests. I think there are very, very few tests that patients would need to go and do out of the country, and further management. And I think if given a chance, our doctors are very good.
Yeah.
And most of them have good intentions and mean well for their patients.
Yeah. I think I agree with that approach. Also with yours, because even at an advantage, you're still at a 6, which is not as high as we'd expect.
Yeah.
But why I agree with that is because we don't talk about like the good healthcare services we have, and they're there. I think the only challenge is price point, where sometimes you're just like, woo.
Yeah.
Whoa, those are many zeros after that particular number. But yes, I agree with both of you.
Yeah.
All right, next question. Patients or profits? Who do you think is the doctor's first priority? Or what do you think is the doctor's first priority?
No, for sure it's patients. I
think you're biased.
I've seen it both as a patient and as the doctor. And for sure, that's my personal opinion, but I think we're still at patient. We have not yet
at profit
lost our do no harm oath.
Yeah,
true.
Yeah. Okay, I think I agree as well. Yeah. Then the next question is, in 2016 we had a national strike. I'm sure you remember that. So apart from pay, what else were we asking for in the CBA?
Oh.
You can give one.
Okay. I think we were campaigning for better working conditions for the doctors and training opportunities.
Yes.
Yeah.
Yeah, I think it was working conditions. Was there something else?
We were also asking for better resources to be able to work.
Yes.
Yes, we can have the best pay or the best environment, but do we have what it takes to treat the patients? So we're also asking for that as well. All right. The next question is, if you won a grant today as a patient, not as a doctor, Samira, what are you improving in terms of the patient experience?
I think I would go first point of contact screening again. There's limited we only go to the doctor when shit has hit the fan.
It's okay.
Oh. And it's unfortunate when you could have prevented some of these things by just screening. So screening is important. And the big grants that are out there, even that we're applying for, and I'm sure you know, are limited to a few diagnoses and like disease groups. And I wish they would just go bigger to even something like NCDs that are emerging and are affecting a lot of our relatives and friends.
Okay.
So
what about for yourself, Doc?
I think maybe to pick on to what I'd said before, I'd use a grant to improve our lifestyle changes. She said about non-communicable diseases.
Yeah.
There's a lot that we can do. If you just look at where we're shooting the podcast, we could do with fields. We could do with running tracks.
Yeah.
We could do with schools that have fields. We could have health awareness programs. So a grant would go towards better lifestyle changes to prevent non-communicable diseases.
I think that's nice. And like more green spaces.
Yeah.
Actually, I love going for open houses. So I just go and see like what are the new developments. And there's one apartment complex I went to, and they didn't have much space. But what I really loved about them is they had a track
Wow.
around the compound.
Oh, that's
And I was just
nice.
like, that's actually so smart.
That's good.
Yeah, so you have the gym, but also you have, if people enjoy running outside, they can use the track. And I was like, I think these are the innovative ideas and solutions that we can also think about when we're developing.
Yeah.
Because as you said, we are in a concrete jungle.
Exactly.
Yeah. And that's why we are flooding, by the way, in case you're wondering. All right, then the last question before we start, and this is for Samira. So Healy Wednesdays, the episodes go out on Wednesdays.
Okay.
Name the part of the body that we're going to focus on today in Kiswahili and its main function.
Oh no. Give me 1 second. Intestines.
Don't know.
Maini.
Yeah.
Oh, yes.
Is it
correct.
maini? Okay,
Yes.
maini. Tuna
Maini.
What's
deal
its
with
function?
maini.
No.
Mine is not liver.
Maini. Oh, we're focusing on the
Is
liver.
maini? Oh,
Wait.
Oh,
shit.
we are doing matumbo. We're doing
Matumbo. Matumbo.
Yes, matumbo.
And
Thank you.
yes.
Thank you.
Matumbo.
Dumb and dumber.
Yeah.
Uh-huh.
Matumbo.
Yes.
Na kazi yake. God help me.
Okay. Ni kutoa uchafu na kurudisha vitu za mwili kwa mwili ambazo
That's
zinahitajika maji na vitu ambazo mwili inahitaji kuendelea.
Okay.
It's good.
Okay. Me, I was going to say food.
Hakiswahili.
Correct.
Yeah.
All right, now let's go to the main agenda for the day, the topic. So we talked about diarrhea in general, and we also mentioned chronic diarrhea. So something that I have been seeing, especially with like my friends, is people have chronic diarrheal diseases that they may know of or sometimes may not know of, and they're not going about it in the right way. So we wanted to have that conversation, especially focusing around IBD and IBS. And we have the specialists in the room, but we also have a lived experience with us. And why Samira is here, I just wanted to find out, so what's your story? And then we can link it now to how do we manage it.
Okay.
Yeah.
How long do we have? I can shorten it.
Yeah.
But I think how I started was just context. I had my gallbladder removed in
Really?
2013.
Oh.
First year of med school, when we were dissecting lower limb. So there's a running joke in my friend group where people say, if you have lower limb problems, like migu problems, don't go to Samira because she didn't dissect. Because I came back when I was doing the upper limb.
Okay.
When we were doing upper limb. We were in the same school.
I didn't even know it. Okay.
Yeah.
Wow.
Yeah.
But it was laparoscopic. It was 3 days. So it's just, not bad. So now I had my cholecystectomy, and then I started we're in med school. It's a high stress environment. And I think that was one of my biggest triggers to getting my IBD. But Doc can elaborate.
Yeah.
So I think in 2019 there, I started having just loose motions. I'll have like debilitating pain, and I'll have like 4 to 5 motions, and I can't like go to school. I can't go to class. I'm not skiving because, we are skiving class, but it's because I'm actually having episodes. But I didn't know they were called episodes then. And then also this year, I had started, I think, my contraceptives. And I think it was also another trigger for me. And then our diet, despite me having a gallbladder removed because of the diet, I don't think I ever changed my diet that much.
You like
so
suffering.
I'm still, yeah. Because now, you know what happens when you have cholecystitis? You are so fat intolerant, you can't even have a bite of anything fatty. You can't you can't do anything. So then the moment the problem was removed for me, I was like, I can have pizzas again. I can have chips again. I can have all this. So I used to indulge. And then we're in med school. You can have the pizza pie and move on and go back to class and like continue with your ward round. So it's easier to have the fast foods. So I think when I started now working is when I started controlling my diet better. Anyway, that's another story for another day. So diet has never changed. I'm having a lot of stress because it's 6th year of med school. And so I'm having this chronic diarrhea that's not, I take Imodium. All it does is just reduce the episodes, but I'm now just bloated and in pain. And then I didn't realize like you're supposed to touch your abdomen and you don't have pain. For me, the entire of 6th year, I was just like, I always have pain when I touch my abdomen. Like it's just constantly, like I'm having discomfort. So again, I'm learning medicine. I'm not telling myself, just go to the doctor. And, I think we are the worst people to seek help.
We're the worst
help.
patients.
Yeah. So finally, a friend of mine, Dr. Fatma Chunai, recommended Dr. Edna to me. And I remembered you actually from, you taught us in third year. And I remember you stuck I remember you often because the first thing you said when you came to teach us that class on cholecystitis was my exact symptoms. And I remember why this was so heartbreaking for me is because it took me 5 different months and 5 separate visits to different doctors to finally be told, oh yeah, this is gallbladder, this is cholecystitis. And we did the ultrasound and it confirmed, and I had to get a cholecystectomy. But why did it take me 5 separate doctors? So I think when you said female 20-year-old, these are the symptoms, and it's common in the Somali community, I said,
Really?
Damn, I wish I knew you then. So I remember texting everyone in class, and I'm like, who is this doctor, and why does she know me? So I think when she reminded me to go to you, I was like, oh yeah, that works. I liked her in third year. So I said, okay, let me go to her. And I remember you sat me down, you listened to my history, and you said, I think let's do tests. So we did some tests, and I remember thinking, I have IBS. IBS was the thing.
Yeah.
So you're like, oh, let's just do a colonoscopy first before we confirm, because what I didn't know then was IBD has to be confirmed on colonoscopy first before you ever think of IBS things.
Okay.
So we did all of our tests. We did a colonoscopy, and that's when we confirmed my diagnosis that I have IBD. And I remember texting people, oh guys, I have IBD.
Yeah.
And then that's it. I started taking mesalamine, and my life changed. I don't have Runnies I don't have to think about, oh, let me eat something so that I don't go to ward round and I'm feeling like I'm gonna have a runny loose stomach and I have to pop an Imodium so that I stay in that ward round, because I feel like I couldn't survive in even ward rounds. I can't, how in theater you would
which
watch.
bathroom would you be going to?
In Kenyatta.
Yeah,
Oh
in
my
Kenyatta.
God.
I remember hating watching surgeries because everyone else can stay and get the signature. I can't, because I can't stand for long, because now I'm having pain and I might need to drop out and leave. So getting the diagnosis actually helped my life, because now I could think of, oh, there's medicine I can manage, I can do this, I can avoid. And then what is the one thing we were surviving on in med school? Coffee. And caffeine was one of my biggest triggers as well then. So that was my diagnosis story. I guess there's more.
Oh, okay. Before we even move to the one, before Doc now explains or breaks it down for us, you mentioned the risk factors for now cholecystitis.
Yeah.
I just remember 5 Fs. Can you name them apart from female?
Female, fat intolerant, I think.
Female, fat, 40, fertile. What's the other F? Can't remember the other one.
Female, fat, 40, fertile.
I don't remember the other one.
Was it family history or something like
Family
history?
Yes, precisely.
And that's important because my mom has.
Yes.
Oh, your mom also
They
had it.
have a lot of it actually in the family history is very important.
Yeah. Okay.
Yeah.
So now we've mentioned IBD, IBS, IBD. Doc, please let us know, what are we talking about? What are these things? Yeah.
So we're talking about 2 different group of diseases that present very similar to each other. So the first one is Irritable Bowel Syndrome, and this is a more common disease. It presents, I'm not sure about the statistics, but in the West it's as common as maybe 5% of the population at different timelines. Then there's Inflammatory Bowel Disease Syndrome, Inflammatory Bowel Disease, and those are very different disease spectrums. Yeah, both of them present with chronic diarrhea. This is diarrhea that stays for a long time, like you've had in Samira's case. It's diarrhea that lingers on for a long period of time. And the presentation varies depending on the severity of either diseases. So, and even the 2 diseases have a very distinct presentation that even from the history you can be able to tell and be able to differentiate. So maybe I can talk about the difference in terms of the history. So inflammatory bowel disease, as the name says, is inflammation. Inflammation means there's an injury to the colon. The colon is the last part of the digestive system. It's a very long tube. And the main purpose of the colon is basically absorption of water and excretion of the stool. So when there is inflammation, the first thing that happens is that your stool cannot be absorbed very well. So you end up going to the toilet many times. And because there's inflammation, you're not able to absorb the water. So the stool becomes very runny. And because there's inflammation, you're going to see mucus in the stool. So that is the slimy things you're going to see, and you're going to see blood. So the key presentation is this long standing diarrhea that has blood in it, that has mucus in it. All right. The second presentation of that inflammatory bowel disease is actually patients who have it at the tail end of the colon. The tail end of the colon is called the rectum, near the anus. You know, most of the times when you go to the toilet, you finish your business and you're done. But these people go to the toilet and they stay and stay and stay because they're not finishing. They have something we call tenesmus. You're not finishing. Because of the inflammation in the colon, you feel like there's always something there. And maybe one of the things that's not spoken about is fecal incontinence. In patients who have very severe disease, they actually leak stool on themselves. Because there is inflammation, they can't even get to the bathroom. They're going to leak stool in their underwear. And because it's very slight stool, it's very embarrassing. But it also comes with other symptoms because it's an inflammatory problem. And most of what I've talked about, mostly one type of it, what is called ulcerative colitis, which is what we deal with around in Kenya. That's the most common. The other presentation that you can have associated symptoms of the back because there's inflammation of the spine. So some of the discs in the spine get involved. So they come with lower back pain. They can come with skin conditions where they have swellings on the skin. They come with recurrent sores in their mouth because there's an inflammatory process. And these can come at the same time or even come separately. And in some cases, we even have the liver involved. So someone can come with a liver disease and then they have a part of the colon also involved. There's a rare form we have another form of the disease called Crohn's disease that can now start from the mouth all the way to the end of the colon. And it can present with recurrent abdominal pain, whereby you get spasms in the tummy. You can get obstruction because it causes narrowing of certain areas. So there are children who will come with, they're always vomiting. You're doing scans and you can't find a problem because maybe there is narrowing on certain areas of the small intestines. As Samira was saying, she was presenting with cramps. Because the colon is inflamed, you're not going to present with your usual diarrhea of just pain of diarrhea alone. You'll have associated symptoms. You'll be cramping, you'll be feeling uncomfortable and generally very unwell, and also lose weight in the process. Then on the other end, there's irritable bowel syndrome. Irritable bowel syndrome, as the name says, is a syndrome. A syndrome means it's a constellation of symptoms. And in these patients, you do not have a physical problem in the colon per se. All right? You do not have inflammation or ulcers in the colon. So you present with diarrhea that does not have blood, might have mucus because the colon produces mucus, but there is no blood. And because the patients are not having inflammation, they do not have other symptoms that are suggestive of inflammation. They might not have back pain. They might just have lethargy because there's a connection with the nervous system, right? And most of this is associated with diarrhea that comes with certain foods. So most people will say, I eat certain things and I get intolerant. I have a very sensitive stomach, but it's a sensitive stomach that does not have blood in the stool. Key, they do not wake up at night to go to the toilet because there is no inflammation in the colon. It's mostly related to males. So their quality of life is generally okay compared to patients who have inflammatory bowel disease. They also present sometimes with, lethargy, mental block. They may say, when I'm anxious, I get more diarrhea, because it has to do with more of the nervous system. But both of them cause chronic diarrhea. And to differentiate, you start by the history. So this patient with bloody mucoid diarrhea with systemic symptoms, you're thinking inflammatory bowel disease. This person with symptoms forever, always looking for the bathroom, but they're generally fine. I've never seen blood in the stool. They don't wake up at night to go to the bathroom. It's more of irritable bowel syndrome.
Yeah. And if I remember well, especially between ulcerative colitis and Crohn's, one was autoimmune, or rather had an autoimmune element to it.
So we think about inflammatory bowel disease as being caused by an autoimmune. So both of them are caused by the autoimmune diseases, where the body kind of reacts to itself. It's like the body begins to be sensitive. It's like the way patients get autoimmune thyroid diseases. The body's fighting itself. They begin to sense certain things in the body as abnormal. They could have been a trigger. They could have been an infection. They could have been something that happened at some point. They could be a family history, which is very, very important in patients who have inflammatory bowel disease. Usually there's a family history of someone in their family having colitis. The diagnoses have not been very good previously. So most people never have a diagnosis before. So maybe you might be the first generation to be identified as having inflammatory bowel disease. One of the things that is actually confused a lot with that is patients who have bloody diarrhea over the years been treated for amoeba. or for infections. So you tell patients, I've always had bloody diarrhea. I'm always treated for amoebiasis. It's not amoeba. How long can you get amoeba? Yeah. So patients who present with bloody diarrhea recurrent, you have to listen to them, but that's where the role of evaluation goes in. What Samira was saying, you have to do your colonoscopy, because when there's inflammatory bowel disease, you'll see a certain pattern of changes in the colon that suggest that there's inflammation. And that will rule out. And that's a mixed diagnosis a lot of times. Or patients think they have inflammatory bowel disease, but they don't have. When you evaluate, the colon is normal.
Okay. Okay, that's interesting. Wow. So Samira has ulcerative.
She has ulcerative colitis. So there are two types of inflammatory, maybe three types of inflammatory bowel disease. The first type is Crohn's disease. Crohn's disease is more in the Caucasians, has a very high prevalence in young people, and has family history is very strong. It starts from the mouth all the way to the end of the colon. The key factor about it, it has predisposition to causing stenosis or narrowing, because it involves the entire wall of the digestive system. So it can block areas, and so people can present with symptoms of blockage, or because it blocks and can go through, it can also present with holes being formed between two organs. So you can even get something coming to the skin, and you can also get ulcers in the anus. So the people come with recurrent like fistulas, like wounds in the colon, and that in the anus rather, and that could be a presentation of Crohn's disease. Then we have a second type, which is ulcerative colitis, which involves the large intestines, and again the presentation also depends on the extent and the severity. Sometimes when you have a very mild symptom, you might never even have a lot of symptoms. The guys who have extreme symptoms will even come as emergencies, because maybe they've perforated or they're very unwell. Then there's what we call an undetermined. So it's not differentiated. You're in between at some point somewhere.
Okay.
Yeah.
Okay.
And the treatments are different.
Okay.
Yeah.
Now,
But
before we get to the treatment,
but they interact.
yeah. Before we get to treatment, and we'll go to investigations, of course. I just wanted to find out from Samira, what was your colonoscopy experience?
Okay. So
walk us through it.
I think, let me start by saying I had an endoscopy before.
Okay.
I came now to Dr. Edna. So in my first ever endoscopy experience with another facility, it was horrible.
Okay.
I felt like I wasn't fully sedated, so I could feel everything. And so the first thing I came and told doc was, I do not want to feel anything if you're putting me under and doing a colonoscopy. So thankfully, I didn't experience much. I could feel some discomfort at the end when I was starting to wake up, where I think I had to prep. So the prep is so long. Oh my God. You have to start, I think, like the night before, during the day. I can't remember now, but it was sometime I had to stop every solid food and then start the color prep. It's a sachet, you mix in 1 liter jug of water and you drink it slowly. It doesn't taste nice. It tastes horrible. It tastes like ORS, and I don't like ORS, so it just tastes meh, you know. So I know you're told not to eat anything, but I normally take a lollipop.
That's a
as
good
I
trick.
drink
Does
my
that count,
water.
actually?
No, that's sugar,
good.
which is
Yeah.
good. I didn't know
Yeah,
that.
so I take a lollipop as I'm drinking my color prep. And then you take Dalcolax. It's like, what's it called?
A
Bisacodyl.
laxative.
It's a laxative, just to help clean the colon. So the idea is to have a very clean, very clean colon with nothing, you know, so that when the scope is passing through, we can see everything and your mucosa and lining and everything. So that took the whole night. What they don't tell you is you're waking up every other 30 minutes to 10 minutes to just pass water. It's like you've turned on a tap. So it's literally you're in the loop. People will think you're peeing, but it's actually that's your colon doing that. It's just
Yeah.
Wow.
So that was me the whole night. I remember even going to the hospital to her. I was like, I don't think you'll be able to pass anything. Like, I'm ready to go back to the loo. Is that okay? And she was like, no, it's okay. It's fine. Don't worry. You just sit on the table. Like, you know, like they've started my dawas. And then I went under, I can't remember much from then, but I remember when I was coming to, I could feel like the scoop now. I think to the last bits, wherever it was, and then now that was it. And even after, you're very much happy and euphoric, you know, because of the ketamine propofol combination. So you don't remember much, and you have to have someone there, which is again something I think that they tell you, which is important, because you're not there, you're still sedated, and it's a day, what's it called, a day procedure. So you go home and sleep it off. So I think it wasn't bad, but that first endoscopy was horrible, because I could just feel like, even just putting your hand in your mouth is horrible. So imagine now a scope constantly going in, and you're not fully under, and you're feeling everything. That, I think that traumatized me. But I think the colonoscopy wasn't so bad.
You've mentioned that, and that's always how I feel about patients who are getting a nasogastric tube, because you're awake and there's something going down your must be uncomfortable.
I became more empathetic by the after that experience.
Being a patient makes you so empathetic.
Precisely.
Now I feel how an NG tube feels. It's not nice.
Okay. Now, Doc, apart from the colonoscopy, how do we investigate for now these different conditions?
So you start off, always you begin with basic tests, and the basic tests are to help you rule out infections. So you start with your stool test, and you're looking to see, has it gone through before, whether there's blood, whether there's any infections, right? After that, you look at your blood counts, and they're telling you does it suggest chronicity? So for people who have inflammatory bowel disease, remember they're losing blood. So you'll find their blood counts are low. If they're having active inflammation, the coach is calling the episodes, then you might find maybe they have white blood cells which are high. Because they're losing blood, their platelets will be high. Then if that is unlike a patient who has irritable bowel syndrome, their blood counts would likely be normal. All right. Then you can do your thyroid functions, because remember, thyroid can also present with chronic diarrhea, but your history will help you differentiate. Does that look like it's from inflammatory bowel disease? If it's thyroid disease, you'll have diarrhea without blood and without mucus in the stool. The next step you do is a colonoscopy, which was alluding to. Maybe for the layperson, colonoscopy is just a tube in a camera. So if I want to look at your mouth, I tell you, open your mouth, and I can see your mouth very well. But remember, the colon and the stomach are very far. So we use a camera attached to a tube, which we put in when you're asleep down the organ we're interested in. So if it's a stomach, that's what she's calling the endoscopy, or the upper GI, then we put it into the stomach. As we do that process, we're looking for several things. Is the lining of the stomach or the intestines normal? All right. So in the patient who is suspecting Crohn's, you're going to do both the upper and the lower GI endoscopies. So in her case, we did the lower GI endoscopy. So you're doing a lower GI endoscopy, you're looking at several things. You're trying to see, is there inflammation, right? Where does it start? Where does it stop? What is the severity? And then you take pieces that go to the lab. So those pieces are called biopsies. Those biopsies are now the ones that confirm the diagnosis together with the history and the endoscopic findings. Then you use that together to make a diagnosis. And based on the location, for ulcerative colitis, it starts from the lower end going upward. For Crohn's disease, it can be patches, so different areas. And finally, the pathologist looks at it and they're able to differentiate on the microscope.
Okay. Now the fun part, management. Samira said after she started now her treatment, life has been smooth. So what is the management apart from that, especially for like IBS and IBD?
All right, let me start with, so in a patient who you're going to have IBS, your colonoscopy findings will be normal. And we don't do colonoscopy in everybody. So let me start. You can make a diagnosis of irritable bowel syndrome without having to do investigation. So you can firmly tell a patient that if in the right population, so these are patients who are less than 45, these are not new onset symptoms, they do not have what we call alarm symptoms. So if you're having diarrhea, you're bloating, and you're losing weight, all right, and you're having anemia on the blood count, that is not irritable bowel syndrome. You have to be investigated. But if you're young, your symptoms, you suggest that you do not have alarm symptoms, you're not losing weight, you don't have abnormal results, then we can make a diagnosis of irritable bowel syndrome. And what we do, we can start treatment. The first thing we do is diet. So we identify what are the triggers, your malabsorptive causes. So you'll have these things that are likely to trigger your lactose, your gluten. And you encourage patients to put a diary and to chart what they're eating and to look at the repetitive patterns. And you'll find most of the people are able to identify certain things that are likely to be causing them to have the symptoms. So the R studies have actually looked, what are the likely things that are likely to be causing diarrhea, which can increase your chances of irritable bowel syndrome. In this case, we're talking about irritable bowel syndrome diarrhea. There's another component that is constipation, but the one that looks very much like inflammatory bowel disease is irritable irritable bowel syndrome, diarrhea. And when you look at that, there are diets that can be followed that are hinged around this we call low FODMAP. These are foods that are less in sugars, which are less in oligosaccharides. These are things which are not easily absorbed. So we talk about a diet that is very easy to digest, less carbohydrate, less sugar, less refined products, less fructose. Fructose is what you get in your juices, your very good juices, your sweeteners that you have. So you're very good mango, but not very good in person who has irritable bowel syndrome because it has fructose, so it's going to increase their whatever, their bloating. You reduce their lactose products. So using that kind of dietary avoidance, you're able to reduce majority of the symptoms. Then you look at their lifestyle and see what are the things that are triggering. Is it stress? If it's stress, you encourage them to have remedies around stress. Is it yoga? Is it meditation? Is it caffeine that is triggering your symptoms? And you reduce that. Then you go to the symptomatic treatment. Then you can have antidiarrheals come in very handy for patients who are having diarrhea. There are medicines that have been tried that try to look at the gut flora, because the gut bacteria is very important in terms of giving you good gut health. So we use certain antibiotics that can return your gut bacteria to the good one. And then we can also give you probiotics. And there's a lot of psychotherapy. You'll find a lot of people, or quite a number of people who have irritable bowel syndrome. There's a psychogenic aspect to that. Not to say that they're sick upstairs, but sometimes there's a trigger. Maybe some childhood trauma, maybe some stress at some point. So you might want to work with a psychologist to help with that. Then finally, because in irritable bowel syndrome, you're thinking about the nervous system not working very well. The medicines that we can give to tweak your nervous system to allow you to absorb things and to tolerate things very well. It's like shutting down an alarm bell. If I'm seated here and I start thinking about some noise, I'll start hearing it, right? In the silence of moment. That's what your gut is doing. It's over listening. It's oversensitive. You're eating, and as the churning is going on in the tummy, your body becomes aware of that. That is more or less what we think about irritable bowel syndrome. So you don't concentrate, because as the gases are being made, you're feeling bloated, you're feeling gassy, which in some cases is normal. It's just that your gut is a bit too sensitive. So we give you medicines to numb it a bit. So you might find us giving you medicine that look like antidepressants. They're not. We're trying to just numb it, to focus yourself on the right things and to make you not listen to what is going on. All right, that's irritable bowel syndrome. Then we have inflammatory bowel disease. Inflammatory bowel disease now requires a structured treatment. So it depends on the type. And there are different levels of treatment for young people. And because over time we have known that it can be very dangerous for patients who have very advanced disease and patients who have Crohn's disease, we might want to go for what you call biologic. You want to hit it very hard. You want the patient to feel very good very fast. You don't want any damage that can be reversible. So when a patient comes in, there are good medicines that are available now, what we call biologics. We have small molecules that work very fast. In a long time, we used to use steroids, and they still have a role in emergency setups for acute management, where you can give a patient very high doses of steroid and then de-escalate and put them on a maintenance. Then there are patients who present with, moderate disease, like in Samira's case, and you go for anti-inflammatories, what we call mesalamine. These are medicines that reduce inflammation in the gut, and they come in different ways. They can be oral, and there's some that you can use topical, meaning that you can put them at the site of the problem. Let's say I do your colonoscopy and you find your problem is very small. It's just on the rectum. There's no point of you taking a tablet. You know why? Because by the time it comes all the way down, it probably has stopped working. It has all been dissolved. I might opt to give you something in a tablet form, like what you give babies. We push it in just to work on that area, or a foam that I can push in that works on the lower end, and they worked very well. And in some cases, there's even limited treatment. So the patients you might want to give for a short period of time, because the disease is very small in a small area. But when you have diffuse disease, it's in a large area, then we use medication, and it's for a long period of time, because we know that when you stop treatment, you're going to recur. Yeah.
Wow. And does surgery have a rule?
Yes, there's rule for surgery, and surgery is usually in the emergency setup. So there are patients who come in and they're in acute, very severe colon, ulcerative colitis especially. And when they come, they're having a pseudocolon. They're almost perforating. They're very unwell. You have to give them medicines, and if it's like a perforation, you have to go in. If you have a megacolon, the colon looks like it's going to burst because of the inflammation, they go in for surgery. Then there are patients who come with very severe disease. They're losing a lot of proteins. They're very, very unwell. Remember, this is inflammation. Those are very sick patients might even end up in ICU. In that case, if you give medicines, and the good thing, medicine has really changed now. So most patients will do very well. But if they're not doing very well by the end of the first week, then normally surgery can have a role. Other patients will tell you, I don't want to take medicine forever. Can we get out the colon? And the colon is a problem. It can be removed. And because treatment has been very expensive, some people cannot afford. And because of that, they've started getting complications. They're not compliant. Remember, ulcerative colitis puts you at risk of colon cancer. And in fact, part of the treatment is surveillance later on. All right. So for patients who cannot be surveyed or have very severe disease, then there's a role for colectomy, removing the colon. And then there's also the role of, sometimes you find there are precancerous things that are growing, then you might need to remove that colon. For patients who have Crohn's disease, surgery can be a rescue because sometimes it can be an obstruction. So you might need to just remove that small area that is having the problem. And if it is a rectum on the lower side, then in that case, maybe there's an abscess. There's a collection of pus that needs to be treated, or it's what we call fistulas, which are small holes. Then they require surgical management in addition to the medical management. So it's actually one of the areas in GI where there's a lot of interaction between the gastroenterologist and the surgeon.
Okay. And sometimes you can be both.
But sometimes you can. There are people who have done both. But I don't think they are not both. They can be a gastrosurgeon. They can do the colonoscopies, but you'll need a gastroenterologist to do the medicines.
Okay.
So there are endoscopists who are surgeons. But when it comes to inflammatory bowel disease and irritable bowel disease, that's medical treatment.
Okay. So, Sawa. Hey, I think this was just an invitation to the public that sometimes put down the Imodium. Just find out what is causing the diarrhea. Okay. Now, I don't think you can end without just touching a bit on colon cancer. Is there anything you'd want people to know about colon cancer?
I think what I'd want to know is one of the most, if there's a word like this, beautiful cancers to treat if detected early. All right. It's one of the diseases that can be prevented. And how do we prevent? Screening. Screening means we look for a disease before it presents. All right. And what are the guidelines in Kenya? We start screening at the age of 45 for people who do not have a family history of colon cancer. So me and you who are fine at 45, you must start screening. And how do we screen at 45? You do a stool test, which is cheap. It's 500 shillings. All right. If it turns out to be positive, then you go ahead and do a colonoscopy. That stool test looks for microscopic blood. Right? If there's positive blood, it means there could be something growing. It could be a small growth. Because what happens in colon cancer, majority of the time, it begins with a polyp. A polyp is a small growth in the colon, which if removed, reduces your risk of colon cancer to 0. And if it is removed, then
to 0?
Yes, it goes back to 0. Once you remove it, it goes to 0, and then we now go to screening, surveillance. Now we follow you up. Now, based on the number and the type of colon polyps that you had. That's for an average person. The other ways you can screen, you can also do something called a CT colonography, though not very good. It's not as good as colonoscopy. So either colonoscopy or you do a full stool test. If a stool test is positive, you do a colonoscopy or a CT scan colonography. There are patients who cannot tolerate colonoscopy for different reasons. There's some role of doing a flexible sigmoidoscopy where you do just a little part of the colon and it gives you an idea how does the rest of the colon look like. If I find polyps on the lower end, it means we have to do the entire colon because it means it could be polyps, all right? But that's for average risk. 45 is a number. It's a new number because we're getting colon cancer at an early age. But we also screen for colon cancer in earlier cases for patients who have symptoms. Maybe now this is diagnostic. So if you come with the blood in the stool, you come with anemia, you're always having diarrhea. We don't say it's hemorrhoids, even if we're seeing them until we're sure that the colon is okay. Because the hemorrhoids could be there, but if you're constipated, why are you getting constipation? Why are you losing weight with hemorrhoids? So if your doctor keeps on telling you hemorrhoids, please insist on a colonoscopy. And this can be as young as people less than 20 years old. We've seen people who are less than 20. Then family history is probably the most important. So our family, as I said, genetics are really underrated. So if you've had a sibling or a relative who has had colon cancer, we take 10 years less from when they had the colon cancer. Let's say you had colon cancer at 40. It means your siblings begin to be screened at 30. So you don't wait to 45. All right. So maybe that's a message that you just look at where you are. You average risk. Do you have any risk factors like a family history, or do you have other history of cancers in your family? So it might not necessarily be colon cancer in your family, but your family has these ovarian cancers. They have these bladder cancers. They have these breast cancers. It means you might have a genetic risk factor that puts you at risk of cancer. There's a syndrome, and so you need colon cancer screening early.
Okay.
Yeah. Or do you have an underlying disease like inflammatory bowel disease? Then in that case, you need colon cancer surveillance or screening.
Okay. I didn't know that you removed 10 years, but I think that's a learning for the day. Okay. Samira, what about yourself? Is there anything you want to tell us about colon cancer?
Yeah, I think if you start noticing any change in your bowel habits, always ask yourself what's going on and always seek help. I think that's how I got to diagnose my IBD because I did not see a well-formed stool in a minute.
Yeah.
And I
You're like,
asked
wow.
myself questions. And I was like, Runny is the new lifestyle. That's not that's not what's it called, a good way to live your life if you're having runny stools. And just before I came here last night, I was looking at my messages. I just searched IBD. I was trying to see my report, and I saw when I searched IBD, it was my entire year of med school and just me telling people, guys, I can't come, I'm having an IBD episode, I can't come, I can't. Like,
Whoa.
I was missing group work, and it's just IBD. And then now that I'm at work, it's because again they're not medics, so I have this way of calling it F1 for the F1 lovers. I call it Verstappening.
Yeah.
So I keep telling my coworkers, guys, I can't come to work, I'm Verstappening.
Yeah.
And like, that's my life. And that's because now I know my diagnosis. Imagine someone who has change in bowel habits, is losing weight, is seeing blood, and is just continuing life without questioning, why am I not having like a test, or why am I not asking myself more questions as to why my bowel habits have changed? I think, so ask yourself questions when your way of life changes a bit in terms of how your body functions. If you start feeling dizzy, if you start having unexplained weight loss, if you start having your bowel changes, that's even, you're at the late stage. You're not even screening. You're not at the screening stage. You're at the let's go get checked stage. And then if you have family history, as Doc said, always screen yourself and your other loved ones, especially if you have cancer in the family. So I think catch it early. It's not like nice down the line. Living with colon cancer.
Sure.
Okay. Maybe before we wrap, how often should we screen? I think.
Okay.
Yeah.
So your index colonoscopy is what determines your subsequent colonoscopy. So if you do your colonoscopy at 45 and it's normal, you screen after 10 years. That's if you have a good preparation. So what Dr. Samira was talking about. Then if we find something, that is what determines. So if you have many polyps, usually when they're more than 3 of a type we call adenoma, then we screen you earlier. If they are, we usually say between 5 to 7 years.
Okay.
All right. And if they're very large, sometimes we bring you back even at 1 year and even sometimes after 6 months. But on average, most people who have polyps about 3 years would be the average.
Okay. So thanks, guys. Before we go to Beyond the Clinic, I think this conversation is also just to reduce shame on the word diarrhea. I think for you feel some type of way saying diarrhea. Diarrhea is normal. It is normal. Okay, not normal. It's something that happens, needs to be checked out when it happens, but don't feel shame just because you're having diarrhea. Yeah. Now let's go to beyond the doctor's seat. I mean, beyond the doctor's seat, beyond the clinic. Yeah. So I think because Doc, you answered these questions in the previous episode, maybe Samira can answer, and where you feel like you can chime in as well, you can chime in.
Yeah.
Okay. So Samira, beyond the clinic, if you were to text your patients right now, just one health tip, what would it be?
Know your values, like know your numbers. So if you've not gotten your annual check, get it now. If you don't know your BP levels as a hypertensive, high blood pressure patient, check it now. If you don't know your sugar levels, check it now. Just know your values.
Okay.
Yeah.
That's a nice
I know. And probably, and what they mean.
And what they mean, yes.
Yeah, and what they mean.
And probably people should stop with the AI. A lot of people are
Yeah.
not seeking medical advice. I think there's still the role of the doctor.
Ah.
I think you're still not a doctor at the end of the day. And
Yeah.
it looks like it's an expensive consultation to even just be asked about your checkup. The things that AI won't tell you. You go to the doctor and she'll do a breast exam. And she'll find something. Or she'll say, oh, you look a bit yellow today, you know? And probably it's the jaundice. So there's still the role of the doctors.
Yeah.
Even in the healthcare profession.
Yeah, correct. Go to your doctor.
Yeah.
Next question. What's the first thing you do for yourself, either in the morning or the last thing you do for yourself in the evening? That's just for your sanity.
I breathe in.
I mean, we all do. If you are not, you'll not be here.
I really love my cup of tea. So first thing I do in the morning when I wake up for the second time, we wake up in the morning to pray and then go back to bed. So for the second time, I just take my cup of tea and I sit on the balcony and I just breathe. Literally, I'm not even joking. I just sit and it just helps me kind of plan out my day because I work in a very fast-paced environment where it's just meetings, work. So just having that little moment to myself and just breathe is important for me.
Okay. Do you have no meeting days?
Yes, Fridays.
Correct. Good.
Fridays are my no meeting days.
Wow.
Okay. Fantastic.
Some people spend their time at work just in
Yeah.
minutes.
Yeah,
In meetings,
true,
sorry.
true,
Yeah.
true.
Okay, then the next question is there a moment where you felt like the body is so wild for doing whatever it's doing?
I think I have dealt with 2 loved ones who have had pancreatic cancer, and I have seen how they start from the moment they've started having the small initial symptoms to what happens just before, there's no more management and it's just palliative. And I just feel like pancreatic cancer is wild for existing. I think, they should not exist. If we can find a way to just eradicate completely, that would be wonderful. Because I feel from the moment you get a diagnosis, you have a narrow window. Even if you catch it at stage 1 and you go to India and you get the whole pancreas removed, and you're still the prognosis is so poor and it's so sad.
That's true. That one day and give you time.
No.
Okay, then the next question is, what's a piece of health advice you were either given or you used to give that you don't necessarily agree with right now?
That BMI is enough to know if you're healthy.
Okay.
Yeah.
Do you want to elaborate?
So you can get your height, weight measured, and then you do a calculation, and you can get your body mass index. Sorry. And if you're within, I think, was it 18.5 to 24.9, you're okay. If you're above 24.9 to 30, you're overweight.
27.
It was 27.
27 point something.
Yeah, then 27, above 27, now you're obese and you're unhealthy, and it's not just that. There's more to your total body, what's it called? Check that can give you more information away from just the BMI.
Yeah.
And maybe more to add to what she's saying, there's now research showing that as you get older, the strength becomes important. Your muscle preservation becomes important. So you don't want to age and just exercise. You have to make sure that you add your body strength. And there are studies to show longevity based on your muscle health. How strong are you? So it's not always bad to be obese, as she's saying. The people who are obese, they get a heart attack and they recover better than people who are very petite. There's more to that. What's your cholesterol levels? What she's saying, know your values, know your numbers.
Correct. I think strength training and resistance training is becoming the talk of the town.
Exactly.
And people are like, get your proteins in because you have to, eat enough proteins to have that strength. So, but it's true, guys. Strength is very important. And also, sorry, on that element of BMI, I think for me, how I approach it is, I don't think it's an indicator of maybe you're unhealthy or not, but I think it's just something that helps in determining risk.
Yes.
So that's how I approach it. So when I'm doing your BMI or when I'm doing my BMI, it's just showing me where I'm at in terms of risk to certain conditions. But yes, there's definitely more that you need to look at. Then the last question is, what's one health rule that you think we should break every now and then without feeling guilty?
Can I chime in?
Yes,
I think it's diet. I think that these people who come in, they're so super conscious about their diet that Monday to Monday, year to year, they eat food that is bland and not nice, take a moment to enjoy. Maybe from seeing patients who can't even eat. Learn the joy of enjoying food. And you want people, if you can enjoy, don't be too guilty. Allow yourself to indulge once in a while.
That's a good one. Especially seeing people who can't eat.
Yes, allow yourself to indulge. You can't eat salads Monday to Monday. I mean, break the rules. Leave.
Leave a little.
Happy gut.
You know? Okay. Have you thought of one?
No, I think I agree with her.
You're such a good doctor. You follow your own rules. Okay, I think that's it for today. Thanks, guys, for coming and helping us learn a bit more about IBS, IBD, and diarrheal disease in general, plus colon cancer. And before we leave, do you want to be found? You can plug yourselves, look at the cameras. Where can people find you?
I'd like to plug my dawa. You can find us at mydawa.com. The cameraman is coming for me. So mydawa.com, you can book a consultation online on the app or the website, and you'll find my team ready to help you with your health concerns before you buy that antibiotic. Thank you.
Or Imodium.
Yes.
What about you, Doc?
So for all your digestive issues, we are at 40 Suits, Upper Hill, 7th floor, room 11.
Okay. And my dawa, please, come, let's talk. Let's talk. Let's work together. I'm looking at that camera. She's looking at this camera. Let's talk. Let's work together.
Usiwambie mara ya?
Nisiwambie mara ya tatu. But guys, thank you so much for listening in, for reaching the end. My name is Dr. Hope Simiu. Follow me on my socials over here. May have all of them. And please also follow the podcast, A Dose of Health. Subscribe on YouTube. I'll give you a moment right now. Okay, you've subscribed. And on all the other platforms that you listen to your podcast, there's Spotify, there's AfriPods, there's Apple. We're also on Amazon. So wherever you listen, please follow us, engage with us, comment. And that's a wrap.